Welcome to our channel viewers. Today's video tutorial is about a patient of gastric cyst in the proximal stomach in which we did laparoscopic proximal gastrectomy with a double track bypass reconstruction. We have demonstrated in detail the resection and double track bypass reconstruction. So this was a patient of 50-year-old male who presented to us with pain in epigastric region for last 1 year. The pain was insidious in onset, delaying, mild intensity with no radiation. For the last 3 months, patient was complaining of pain, aggravating with meals and accompanied nausea but no vomiting. He also complained fullness after taking meal with loss of appetite and undocumented weight loss. There is no history of any jaundice or GI bleed. His general physical examination was normal. In the abdominal examination, there was a deep tenderness in the epigastric region. The rest of the examination was normal. His rectal examination was normal. The CT scan of the abdomen revealed 6.5 into 6 into 4.5 cm polypoidal enhancing soft tissue lesion involving gastric cardia reaching G junction proximally with the hyperdense content in the central part to show necrosis. We can see in the axial images there is a large growth in the proximal part of stomach reaching up to the G junction with central necrotic areas. These are the sagittal images of the same patient. Again, this growth is illustrated well, reaching up to the G junction with the central necrotic areas and hypodense content within. It is reaching up to the proximal 1/3 of the stomach and fundus of the stomach. These are the colored images of the CT scan. Again, the growth is demonstrated. Patient though was not complaining of any difficulty in eating, but this growth is obstructing the G junction partially. On upper endoscopy, there is a large polypoidal ulcerator growth seen in the fundus reaching up to G junction proximally and fundus body region distally. The cyst with malignant potential, Ki67 leveling index 60%. It was immunoreactive for DOG1 and c-KIT, which is a diagnostic IHC marker for cyst. So we made a diagnosis of cyst in the proximal stomach reaching up to G junction. Coming to the relevant literature review, the most common of GI location of cyst is stomach in 56% cases, small intestine 32%, colorectal 6%, and esophagus less than 1%. The rule by anastomosis first time was done by or after total gastrectomy. In 1965, Kajitani and Sato reported the use of DTR, that is double track reconstruction. Unpopularity of proximal gastrectomy is because of the high incidence of reflux and anastomotic stenosis, because historically we have been anastomosing stomach, remnant of the stomach to the esophagus. There are more than 70 types of restoration of GIT continuity after gastrectomy described in literature. The DTR is based on Roux and Bai with additional gastroesophageal after proximal gastrectomy or duodenal gastrostomy after distal gastrectomy and total gastrectomy. The advantage of DTR is that the remnant stomach is available and high probability the patient can have one-time meal, and there is a laparoscopic access available to the endoscope, and it improves quality of life. The indication for surgical section of cyst are when the size of tumor is more than 2 cm. There are high-risk feature may indicate section for smaller cysts, which are given in the table alongside. When the cyst is symptomatic or when the cyst is growing mild under surveillance, if the patient is not meeting resection criteria, the surveillance endoscopic ultrasound should be done every 6 to 12 months. The Fletcher criteria of cyst risk assessment are very low risk, intermediate risk, and high risk. Very low risk is when the tumor size is less than 2 cm and mitotic count is less than 5. Low risk is when tumor size 2 to 5 and mitotic count less than 5. Intermediate, there are two categories: tumor size less than 5 and mitotic count 6 to 10, and the size is 5 to 10 and mitotic count less than 5. High risk is more than 5 cm, more than 5 mitotic count, or any tumor which is more than 10 cm, or any tumor with more than 10 mitotic count will be high risk tumor. The IC staining is the cornerstone of the diagnosis. The CD117, this is primary criteria and pathological diagnosis, sensitivity is more than 95%. Platelet-derived growth factor receptor alpha, also Markova GIST, with a frequency of approximately 15%. It is used in combination with c-KIT or as a Markova GIST that lack the c-KIT mutation. Dog1, that is discovered on GIST, utility diagnosis of tumor that lack c-KIT and PDGFRA. Dog1 has an overall sensitivity of 95%, similar to the KIT. So, what is the value of neoadjuvant biological therapy before before surgery in a GIST? So, GIST in which there is a local invasion or we cannot achieve a arterial resection. So, neoadjuvant therapy is indicated and it gives very good result. In a study by Laparoscopic et al., 161 locally advanced non-metastatic GIST, there was an 80% tumor response and 83% arterial resection could be achieved, and only 2 patients showed progression during the therapy. We used imatinib for the neoadjuvant therapy, and 5-year disease-free survival was 65%. In another study by Tiran et al., 57 locally advanced GIST were given neoadjuvant therapy. The median tumor size reduced from 12 to 6 cm before surgery, and arterial resection was achieved 84% of cases. So when there is a local invasion, locally advanced GIST, neoadjuvant therapy has definitive role, and there is a high probability of achieving arterial resection following imatinib therapy. So there are different reconstruction methods after gastrectomy. In the diagram A, this is DTR after proximal gastrectomy, beaded esophageal, that is, it is shown that esophageostomy, gastrointestinal jejunoctomy. In the diagram B, double track reconstruction after distal gastrectomy, we will add duodenojejunoctomy in this case, and DTR is possible by esophageostomy and duodenojejunoctomy, and jejunoctomy is added to completion. Okay. Other methods after proximal gastrectomy can be esophagogastroscopy, that the remnant stomach is brought up and anastomosed to the esophagus, but as I said, it is to be discouraged as there are high chances of reflux and anastomotic stricture, and the quality of life is not good, especially in the young patient. Other is ruined by reconstruction, that is diagram E. Another one is ruined by reconstruction after total gastrectomy, that is esophageostomy and jejunoctomy. So why not esophagogastroscopy after laparoscopic proximal gastrectomy? As I said, this anastomosis is to be discouraged because there is a high incidence of reflux esophagitis and anastomotic stricture. In a study by Abrutani T et al., they studied 19 patients of DTR and 22 patients on esophagogastroscopy. The reflux symptom was 10.5% versus 54.5%, and PPI usage was 31.6% versus 72%. Both were statistically significant. The anastomotic stricture rate was 0 versus 27%, and DTR fared well both in form of symptom and anastomotic stricture. So this is a schematic illustration of DTR with fluoroscopy using dye, and it is showing contrast medium showed half of the medium passing through the remnant stomach and rest directly to the jejunum. So in the DTR, the remnant stomach is available for the food, and patient can have one-time meal. And as I said, there is a lesser chance of reflux esophagitis and anastomotic stricture. So DTR is better mortality after proximal gastrectomy, and esophagogastroscopy is to be discussed at all the times. This is a comparative study of DTR versus ruined by reconstruction after gastrectomy for gastric cancer by Jung Hong et al. In this study, 595 patients from 8 studies, a meta-analysis were there, and 262 were DTR and 333 were ruined by. The study reported that there was a significant shorter time to oral intake in the DTR group than the ruined by. Rest of the parameters were comparable in all aspects. So In the same study, they reported that the weight change at 2 years after surgery, the decrease of body weight was significantly more in the group of ruined by reconstruction than the DTR double track reconstruction 2 years after the surgery. This is another study by Rosa et al. Total versus proximal gastrectomy for adenocarcinoma upper third of the stomach. And they reported that a proximal gastrectomy with the esophageal there is a higher frequency of stenosis and reflux than did total gastrectomy. But again, as I said, the DTR could have decreased the incidence of reflux in this patient, and they reported the reflex esophagitis and anastomonic stricture were higher after proximal gastrectomy. Iwahashi M. et al. Evaluated the double track reconstruction after total gastrectomy in patients with gastric cancer. It was a prospective randomized controlled trial. Total 44 total gastrectomy, randomized 23 ruined by and 21 double track. They reported that there is no substantial advantage of double track reconstruction after total gastrectomy when compared to the simple ruined by method in terms of body weight, quality of life, and nutritional condition. But we have to keep in mind that in DTR there is a very big advantage that there is a endoscopic access to the ampulla. In future, if there is any requirement of endoscopic procedure for like endoscopic biopsy of the ampulla or for the cholecystectomy, then this route is easily accessible after DTR, and in my opinion, that is a very big advantage for these patients. So, in summary, double track reconstruction useful reconstruction method after laparoscopic proximal gastrectomy. The function preserving operation retain distal stomach and increase single meal food intake and improve quality of life of the patient. There is a possibility of endoscopic access to the ampulla better, and that can be achieved after DTR. DTR can be safely performed after proximal gastrectomy, distal gastrectomy, or total gastrectomy, and more randomized control trials are needed to prove the superiority of this technique over others. Thanks for watching, viewers. I hope we have added some new insight to your knowledge and you will be able to incorporate double track reconstruction in your surgical methods. Kindly like and subscribe this channel, and the channel subscription is free for lifetime and knowledge is priceless. Be our catalyst in this journey of ours of digital learning. Thank you very much.